Before we start, I want to thank our generous sponsors. Merck is one of the key sponsors of this program. Our first speaker is going to be Dr. Sherita Golden. The full bios are in the booklets that you have, so I'm not going to read her full bio and the full bios of the other speakers, otherwise we'll be here for a long time. Dr. Golden is the Hugh P. McCormick Family Professor of Endocrinology and Metabolism and Vice President and Chief Diversity Officer for the Johns Hopkins Medicine at Baltimore, Maryland. Dr. Sherita Golden.
All right, good morning, or afternoon. I'm so confused because I'm from the East Coast. It is actually night where I am. Good afternoon here, Honolulu time. So aloha. So I'm going to talk this afternoon about what's new in the diabetes management guidelines. And I'll just start with one disclosure that I am a member of the American Diabetes Association National Board of Directors, and I just mention that because I will be reviewing the American Diabetes Association's clinical practice guidelines, but this is voluntary and uncompensated. So this is your first question, and we're going to pose these questions again at the end. So which glucose-lowering therapies have been shown to reduce cardiovascular events and mortality in patients with type 2 diabetes? So this is like Jeopardy. I just don't have the music. Okay, so there's the majority of you chose A and C, so liraglutide and empagliflozin, and we will reveal at the end which one is the correct answer. And this is your second question. So first-line therapy for type 2 diabetes, absent contraindications, is which of the below therapies? Okay, so the majority of you picked metformin. So we will confirm at the end how you all did. Okay, and this is the last pre-test question. All of the following diabetes therapies cause weight gain except which of the below? All right, and the majority of you picked DPP-4 inhibitors. All right, so just to talk about our objectives this afternoon, the first will be to articulate the patient factors to consider in selecting pharmacological therapy in patients with type 2 diabetes. The second will be to articulate the type 2 diabetes therapies with beneficial effects on weight gain and cardiovascular disease. And then the final will be to articulate the evidence-based recommendations for initiating as well as escalating therapy in type 2 diabetes. So just to remind you that the main pathophysiological defects in type 2 diabetes, and I think it's important to revisit the physiology because there are multiple, particularly of our newer agents, that are targeting each of these different pathways. So we know that there is the development of insulin resistance at the level of the skeletal muscle, and I'm starting with that, but we're not sure if these things occur in sequence or together. But there's decreased peripheral glucose uptake, so insulin resistance at the level of the skeletal muscle, and there is also increased insulin resistance at the level of the liver. So typically, if you have normal glucose tolerance, if you have glucose in your plasma already, then it shuts the liver down and it suppresses gluconeogenesis. However, in the setting of type 2 diabetes, insulin is resistant to that effect, so the liver will continue to make glucose even though the patient already has insulin resistance or hyperglycemia. So to compensate for that insulin resistance, the pancreas tries to increase its level of endogenous insulin production to try to maintain normal glycemia. And when the pancreas is no longer able to do that and there's beta cell dysfunction, then hyperglycemia and type 2 diabetes develops. And so this is important because a lot of our pharmacological therapies now target these different pathophysiological mechanisms. And so we know, for example, that there's also a decrease in incretin effect at the level of the gut. So in response to oral glucose intake, the gut incretins, which normally help lower glucose, those levels are low in the setting of type 2 diabetes. And then we also know that there are also central mechanisms that control appetite that are also defective in type 2 diabetes. So when we think about all of our oral agents, they are actually targeting these different mechanisms. And so we have two classes of insulin sensitizers, so metformin as well as thiazolidine diones. Then we also have insulin, and that they act primarily at the level, the metformin acts primarily at the level of the liver, the thiazolidine diones primarily at the level of the adipose tissue, as well as the skeletal muscle. Then we also have insulin secretagogues, which are trying to increase insulin secretion. So these are some of our oldest agents. So we have the sulfonylureas, and we also have the metglitinides, and the metglitinides are short-acting sulfonylureas. We also have the alpha-glucosidase inhibitors that inhibit glucose absorption from the gut. And then we have the incretin. So over here are some of our newer agents, the incretin mimetics, so DPP-4 inhibitors, which I'll talk about in a second, as well as GLP-1 receptor agonists. We also have the amylin mimetics. So amylin is another hormone produced by the alpha cells in the pancreas that have a very similar mechanism of action to the incretins. And then we have bile acid sequestrants, which, so silvasalam lowers glucose levels for a variety of reasons, as you can imagine, because of their GI side effects. They're not really used very often. And then there are the dopamine 2 receptor agonists, which have also been shown to have glucose-lowering effects. Again, not used as commonly because of side effect profile. And then the newest agents on the block are the Sglt2 inhibitors, or sodium glucose transporter 2 inhibitors, and they impair the absorption of glucose from the kidney and result in glucoseuria and lowering of glucose. So again, this is just to review the classes. The biguanides or metformin, again, improves insulin sensitivity, typically has either a weight neutral effect or some slight decrease in weight, and also has a beneficial effect on cardiovascular disease. I'm not going to go through all of the advantages and disadvantages, but these charts, which are also in your handout, give you a sense of their costs as well. The sulfonylureas we've mentioned increase insulin secretion, and they've been shown to reduce the risk of microvascular disease. The main side effects are hypoglycemia and weight gain in particular. The thiazolidine diones activate PPAR gamma and increase insulin sensitivity, particularly at the level of adipose tissue. They do not result in hypoglycemia and have some beneficial lipid effects. However, they do cause weight gain as well as edema and heart failure. And there's been a question, particularly with rosiglitazone, about an increased risk of MI, and with pioglitazone about an increased risk of bladder cancer. So there are some adverse side effects with these. The alpha-glucosidase inhibitors impair the absorption of glucose, and their primary side effect are GI side effects. And then we have the DPP-4 inhibitors that are part of our newer class of agents, and what these do is they inhibit the enzymes that break down our endogenous incretins so that levels of GLP-1 and GIP both increase and have their beneficial effect. They don't cause hypoglycemia and are generally well tolerated except for GI side effects. And then there's the GLP-1 receptor agonists, and what they do is they activate the endogenous GLP-1 receptors, and in addition to increasing insulin secretion and suppressing glucagon, they also slow gastric emptying and increase satiety. So they result in some weight loss with minimal hypoglycemia, but again, primary side effects there are GI. And then the amylin mimetics have a very similar mechanism of action and side effect profile as the GLP-1 agonists. And then finally, the bile acid sequestrants we talked about a little bit. They impair hepatic glucose production, but do have some significant GI side effects. Dopamine 2 receptor agonists, again, the side effect profile prevents these from being used as much. And the Sglt2 inhibitors, we talked about their mechanism of action a few minutes ago. They also, in addition to having a low risk of hypoglycemia and having a weight loss effect, also help to reduce blood pressure. Their primary side effect is volume depletion and urogenital infections, again, because there can be glucose sitting in the bladder. And then, so insulin is actually, I call it the universally effective glucose management agent. There's no dose that's too high, has an unlimited efficacy, but obviously there's association of hypoglycemia and weight gain, as well as a stigma associated with insulin use. So I just want to mention some facts about insulin therapy, and we'll have a whole talk on the insulins. It is the oldest therapy for diabetes treatment. We have the greatest clinical experience. It's most effective, so in other words, no matter how high the hemoglobin A1c level, adequate insulin titration can bring that down to a therapeutic target. And then it can be used with oral agents as a combination in type 2 diabetes. And this is just a reminder of the insulin action profiles. And so the rapid-acting insulins, which are used before meals, are our aspart, lispro, and glulisine. And then we have regular insulin, which has a longer duration of action, so has both nutritional insulin as well as basal components. And then the long-acting insulin, so we have MPH insulin, which typically is used twice a day. But then we have the peakless insulins now, and we really have three. We have glargine, detamir, and degludec, and these agents have a duration of action of at least 24 hours, and some have a longer duration of action. And we're going to hear more about insulins shortly. So this is just a summary of the insulins, and to remind you that there's also the insulin mixes, which I typically as an endocrinologist are not in favor of. However, for patients that only want to take 2 shots of insulin a day, sometimes the pre-mixes are an alternative. So what's the approach? We have all these great agents. What are our approaches to managing hyperglycemia and diabetes? So the one thing I don't want us to forget about when we're talking about drugs is the importance of diet. And so what this cartoon says is that you've got to start eating out of a different parking lot. So it's important to remember that lifestyle is an adjunct to everything that I'm talking about here. So weight loss and weight optimization are really crucial. The goal is to lose 7% of your body weight, and we know that in the diabetes prevention program that was effective in lowering the risk of diabetes significantly. Physical activity is recommended at 150 minutes per week, and this can be as simple as 30 minutes of walking 5 days a week. And then also a healthy diet, which really encourages decrease in saturated fat intake, an increase in monounsaturated fat, and really increasing the servings of fruits and vegetables a day to 5. So in terms of what's new in the guidelines, ADA this year really came out with some more specific recommendations around medical nutrition therapy. So they recommended that it be delivered by a registered dietitian who's knowledgeable in diabetes-specific medical nutrition therapy. That has actually been shown to lower A1C by about 0.3 to up to 2%. And then the other thing is in terms of eating patterns and macronutrient distribution. So I think patients have gotten a lot of confusing information. And so there's actually no single ideal dietary distribution of calories among the carbohydrates, protein, and fat, where one is more beneficial than the other. So for many of my patients who want to do some of the other, like the weight loss programs, a lot of it is around portion size. Whichever one works most effectively for that patient that's healthy is what is currently recommended. So a variety of eating patterns are actually acceptable. So then what factors should we consider in selecting these therapies? So one is how great of a reduction is needed in the hemoglobin A1c. So you can see that there is a range in efficacy in A1c reduction among all the classes of these agents. So that's the first place to start. The second is the patient overweight or lean? So how much is insulin resistance a contributing factor? And so we know that the sulfonylureas, insulin, and thiazolidinediones cause weight gain. We know that metformin, the GLP-1 agonist, and the Sglt2 inhibitors all promote moderate weight loss. And then we know that there's the metformin and the DPP-4 inhibitors can be weight neutral. So I think, what the patient needs to accomplish in terms of weight loss is crucially important here. And then does the patient have comorbidities that really are contraindication to some of our therapies? And so, for example, for metformin, if patients have renal insufficiency, that can be a relative contraindication. I think what's nice now is that we know up into an eGFR of about 45 that it's safe to use metformin, so we can use it in a much larger population than we could previously. If the patient has treated congestive heart failure, that's going to be a contraindication, as well as binge alcohol use, because they can increase the risk of lactic acidosis. And then the thiazolidinediones are contraindicated in anyone with active liver disease or class 3 or 4 decompensated heart failure, and also generally not recommended in individuals with a risk for bone fractures. And then the Sglt2 inhibitors, again, these are contraindicated in individuals at risk for bone fractures or who could suffer side effects from hypovolemia or already have issues with genitourinary infections. And then among our GLP-1 analogs, so because they slow gastric emptying and cause early satiety, they're contraindicated in individuals with gastroparesis because it can worsen the condition, and also pancreatitis. So the GLP-1 analogs have been shown to be associated with an increased risk of pancreatitis. So individuals with a history of that, we generally don't recommend these agents. And also if there's a history of medullary thyroid cancer, again, is a contraindication to using these agents. And then the fourth question is, does a patient have cardiovascular disease? So hypoglycemic agents have been shown to reduce the adverse effects of cardiovascular events and mortality, include the GLP-1 agonists, so specifically liraglutide, as well as the Sglt2 inhibitor and empagliflozin. And then are there potential health risks to the patient for hypoglycemia? So this is particularly true in the older population. Do they have active cardiovascular disease or active neurological disease? And so fortunately now we have an array of therapies that when used as monotherapy do not cause hypoglycemia. If you use any of these agents with a sulfonylurea or insulin, then there's an increased risk of hypoglycemia, but at least as monotherapy, these agents are safe for those who have a high risk of hypoglycemia. So the A-level evidence for pharmacological therapy is that metformin, if it's not contraindicated and if it's tolerated, is recommended as first-line pharmacological therapy in type 2 diabetes, and that it should be continued when used in combination with oral oral agents. It can also be used in combination with insulin. So then, in most patients who do not have cardiovascular disease, if you're using monotherapy or dual therapy that doesn't achieve the A1C over 3 months, then you want to add a second agent to the regimen. If they do have established cardiovascular disease, then when you're needing to add that second agent, then you want to consider adding an agent that's been proven to reduce the risk of cardiovascular disease events. So that's one of the newest things in the guidelines over the last year. And a lot of that comes from data. This is a study that was published in JAMA last year that looked at a meta-analysis of 236 trials involving over 100,000 participants. And essentially it showed that the Sglt2 inhibitors and GLP-1 analogs reduce all-cause mortality as well as cardiovascular disease mortality. And the Sglt2 inhibitors in particular also lower the risk of heart failure. So this is why now the guidelines are incorporating this important consideration in selecting therapies. And so this is the current ADA's clinical practice algorithm, and it does look a little bit like a word puzzle. So I'm going to try to break this down for you now into, I have 5 minutes, okay, I'm going to break this down quickly into the considerations that we just walked through. So if a patient does not have established cardiovascular disease or chronic kidney disease, then you want to use, as we mentioned, one of these agents that has a proven cardiovascular disease benefit. So this is after metformin. You want to add your GLP-1 analog or your Sglt2 inhibitor. If they have heart failure or chronic kidney disease, then you also want to add your Sglt2 inhibitor. So again, this is sort of like your second-line therapy if your hemoglobin A1c is not reaching target. And then again, once you've added one of these agents, if they're still not reaching target, then there's recommendations for what the third line of therapy should be. And these footnotes here are just the footnotes in those figures so that you can know what they are when you go back for your reference. And then if the patient doesn't say that we are sort of now not considering cardiovascular disease, is there a compelling need to reduce hypoglycemia, then you really have 4 choices. It's the DPP-4 inhibitors, the GLP-1 analogs, the Sglt2 inhibitors, or the thiazolidine diones. And so, among that, you're looking at, essentially what I end up looking at is what does the patient's pharmacy formulary allow me to prescribe that's affordable, where they also don't have a contraindication or a side effect. And then the next is there a compelling need to minimize weight gain? So again, there we're looking at one of the incretin mimetic agents if your hemoglobin A1c is not reaching target. And then the final consideration is cost a major issue? Some of the cheaper agents are the sulfonylureas and the thiazolidine diones because they've been out on the market for longer. Unfortunately, insulin therapy used to be one of the cheaper, but insulin prices have increased significantly, and we probably could have a whole discussion on that topic. So then in the last couple of minutes, I just want to talk briefly about, this is the ADA's algorithm for injectables. And again, there are quite a few arrows on here. You know, as endocrinologists, we have a lot of pathways, but I'm going to simplify this. The main points from this particular slide are the following. So when you're thinking about injectables for your patients, then you want to consider an initial injectable combination if the A1C is over 10% or 2% above your goal. And what you want to do is, again, remember the patient's on metformin, you want to add a GLP-1 agonist along with a basal insulin, or you can add basal and prandial insulin together. I find that oftentimes patients have a hard time going from, a metformin to a basal and prandial regimen, so sometimes doing the 2 once-a-day injections may be a quicker way to transition them there. If your hemoglobin A1c is above target despite dual or triple therapy, so now we have patients on 2 or 3 oral agents, then you want to consider a GLP-1 prior to insulin therapy. And then if you're still not at target, then you want to add the basal and nutritional insulin. And then an important consideration is insulin can often be a first choice if the patient is extremely symptomatic, has symptoms of catabolism, so polyuria, polydipsia, weight loss, so really severe extreme hyperglycemia, usually with an A1C above 11%, it's appropriate to start with insulin. Or if you suspect the patient has type 1 diabetes because they don't fit the typical phenotypic profile of type 2 diabetes, it's always safe to start with type 1 diabetes while you're doing your antibody assessment. So just to remind you, these are our hemoglobin A1c targets, and glucose targets really have not changed. A preprandial glucose of 70 to 130 with a postprandial glucose of less than 180 and an A1c target of greater than 7%. And the target may be more strict or more lenient depending upon whether the individual has comorbidities and what their life expectancy is. And I think at the end, the goal is to tighten glucose control by avoiding hypoglycemia. So in the last 2 minutes that I've been told I have, just want to talk about this recent controversy last year related to hemoglobin A1c targets that was put out in the American College of Physicians statement. Do any of you all remember seeing this when it came out? So in comparing the existing guidelines as was done in this article, this is basically showing all of the guidelines that existed at the time and what the hemoglobin A1c targets were recommended. And you can see that they were all quite variable. There was a lot of heterogeneity here. And so the ADA's guidelines basically said that clinicians should personalize goals for glycemic control in patients with type 2 diabetes on the basis of a discussion of the benefits and harms of pharmacotherapy, the patient's preferences, the patient's general health and life expectancy, and the treatment burden and cost of care. So essentially everything we just walked through in the ADA's algorithm. And then, so that was a part of the ACP statement that the ADA agreed with. And then the fourth statement, which we also supported, is that clinicians should treat patients with type 2 diabetes to minimize symptoms related to hyperglycemia and avoid targeting A1C levels in individuals who have a life expectancy of less than 10 years due to advanced age, residence in a nursing home, or chronic conditions. So where basically the harms outweigh the benefits. So there was alignment there. So where there was a lack of alignment was on the second guidance statement, was that clinicians should aim to achieve an A1C between 7% and 8% in most patients with type 2 diabetes. So the concern there is that evidence from clinical trials really supported an A1C target of around 7% to prevent microvascular complications, and that there were potentially adverse effects in women of childbearing age, for example, of recommending an A1C target of 7 to 8% in most individuals. There's also a positive legacy effect for tight glycemic control, and that was shown both in the UK PDS as well as the Diabetes Control and Complication trial. So we know that earlier in the life course of diabetes that we control glucose, then there's a long-term benefit on both micro and macrovascular complications. And then there's also the effect of the newer medication classes that now do not promote weight gain that may have a beneficial CVD effect that had not been considered. And then the final guidance statement where there were concerns is that clinicians should consider de-intensifying pharmacological therapy in patients with type 2 diabetes to achieve a hemoglobin A1c level of 6.5%. And so we feel that de-intensification should really be based on patient factors and not a specific hemoglobin A1c target. So if a patient has an A1c of 6.2 with no hypoglycemic symptoms, I wouldn't necessarily de-intensify that patient. And then finally, if there's minimal or no hypoglycemia risk, collective evidence really does confirm that a lower A1c reduces the risk of complications, and there's really never been any lower limit that we've been able to find at which below that limit it's no longer beneficial. And then the final point was that avoiding a target hemoglobin A1c in patients with a life expectancy of less than 10 years due to advanced age, considering 80 years or older. So I have members in my family that are around 80 years of age that are actually walking around and doing just fine. I think you have to actually look at the comorbidities. Every 80-year-old is not the same. So that's, I just wanted to sort of give you a perspective on those targets, and I'll be happy to take questions with the other panelists at the end of this section. Thank you. Okay, so now there's a quiz, see how good of a teacher I've been. Okay, so which glucose-lowering therapies have been shown to reduce cardiovascular events and mortality in patients with type 2 diabetes? All right, excellent. So most of you have gotten this right the first time. So A and C, so liraglutide and empagliflozin. Liraglutide is a GLP-1 agonist, and empagliflozin is an Sglt2 inhibitor. So those are the two classes with a beneficial CVD effect. Okay. So then the first-line therapy for type 2 diabetes absent contraindications is, all right, so almost 100%. So metformin is the recommended first-line therapy. So again, the ADA's algorithm starts after metformin. And then all of the following diabetes therapies cause weight gain except. All right, excellent. So almost the majority. So DPP-4 inhibitors, all of the other therapies are associated with weight gain.
Thank you.
All right.